Good morning, my dear students. Today's our topic is acute bronchitis and pneumonia, outpatient aspects of diagnosis and treatment. And now we're talking about acute bronchitis. Acute bronchitis is acute, reversible, diffuse inflammation of pseudoluminary or the bronchi mucosa without involvement of the lung parenchyma. The main clinical symptoms of which is a cough. It can be or dry or with sputum, less and no more than 3 weeks. Acute bronchitis ranks among the top 10 most common outpatient illnesses in the United States, affecting approximately 5% of adults annually. Classification of acute bronchitis. It can be classified according to the level of bronchial damage. It can be proximal, distal, or bronchiolitis. Bronchiolitis is more specific for children. By the nature of inflammation, it can be catarrhal or purulent. According to ventilation impairment, it can be non-obstructive or obstructive. According to the nature of the cough, it can be acute. It's according to 2-3 weeks. It can be prolonged more than 1 month and recurrent. It's 3 times or more during the 1 year. According to the presence of complications, complicated or uncomplicated. It's according to talking about complications can be complicated by emphysema, respiratory failure, and hemoptysis. According to the etiology, there are metastases according to viral, bacterial, mixed etiology, or can be viral, bacterial due to chemical exposure, due to physical exposure, and unexpected. Etiology. Viral infections such as a common cold or influenza viruses, adenoviruses, or rhinoviruses. It can be frequent instigation, also exposure to irritants or other respiratory pathogens can also be putative triggers. Those viruses are transmitted through respiratory droplets and include inflammation and irritation within the bronchial tree, ultimately leading to the characteristic symptoms of acute bronchitis, which causes cough and sputum production and respiratory discomfort. Bacterial pathogens play a role is approximately 10 or less of acute bronchitis, so it means it's viral, it's more common reason of acute bronchitis. Among these bacterial pathogens can be Mycoplasma pneumonia, Chlamydia pneumonia, or Bacillus pertussis. They are most commonly infected offering. In constants, their majority approximately from 90 to 95% of causes in healthy adults are attributed to viral infection. Exposure to irritants such as smoke, contamination, air dust, and other environmental pollutants can also cause acute bronchitis or exacerbate pre-existing respiratory conditions. Furthermore, allergens can trigger all allergic response within the airways, ultimately culminating in inflammation and the onset of bronchitis symptoms, particularly in individuals who are susceptible to such triggers. Pathophysiology. Acute bronchitis is inflammation affecting the large or mid-sized airflow bronchi, frequently precipitated by a viral infection. The inflammation of the bronchial bone leads to mucosal thickening, epithelial cell desquamation, and denuation to the basement membrane. In some symptoms, a viral upper respiratory infection can progress to a lower respiratory tract infection, resulting in acute bronchitis. The symptoms. In the early stage of infection, the symptoms of mild upper respiratory infections and acute bronchitis can often overlap, creating a challenge in distribution between both based only or symptoms. Both conditions may present with common respiratory symptoms such as cough, mild fever, fatigue, and body ache. Cough. Initially, the cough may start as dry irritation, but as acute bronchitis, advance its can transmission to production sputum. In acute bronchitis, this cough tends to persist and for longer, often extending beyond 5 days. Approximately 50% of patients with acute bronchitis report the production of purulent sputum. Prolonged or forced coughing may lead to chest wall or substernal musculoskeletal pain, usually self-limitation. Mild fever. Low-grade fever may be present in both conditions. Also, it is more frequently associated with upper respiratory infections. The presence of high-grade fever is a sign of acute bronchitis and usually and warrants further diagnostic evaluation. Fatigue and body weights. Mild upper respiratory infections and acute bronchitis can cause fatigue and general bodily discomfort. Physical examination. We can see lung, it's of course lung auscultation may reveal the presence of wheezing. In some instances, the direction of bronchi may improve or clear with coughing, suggesting that the oral secretion obstruction causing the sound can be elevation through coughing efforts. What can we use for diagnosis? Chest X-ray. Chest X-ray finding cause of acute bronchitis are generally non-specific and often appear normal. The chest X-ray finding may occasionally reveals increased interstitial making indicated or bronchial wall thickening. Chest X-ray provides particularly valuable is the disturbance in pneumonia from acute bronchitis when infiltrated are present. Evidence-based guidelines established by American College of Chest Physicians recommended obtaining of chest X-ray where specific criteria are met, including the follows. It is heart rate equal to 500, respiratory rate greater than 24 breaths in a minute, oral body temperature 39 and more, chest examination findings or FAG or Limitus. Laboratory testing, including complete blood count and chemical panel, may be considered a part of the diagnostic workup for fever. The white blood count may show a light elevation in some cases in bronchitis. Rapid microbiological testing for respiratory infections may not always be cost-effective or essential in every situation. Nevertheless, specific scenario exists in which testing can be definitional and potentially result in alteration to the treatment approach. Multiplex polymerase chain reaction testing, or nasopharyngeal verbs, aspiration of the diagnostic tool that allows for the simultaneous detection of multiple pathogens in a single test. Spirometry. When performed, reveals transist bronchial upper responsibilities in approximately 40% of patients with diagnostic acute bronchitis. A reported 70% of these patients exhibit responsibility of VIV1 greater than 50%. Airflow obstruction and bronchial upper responsibilities typically resolve within 6 weeks. What according to treatment and management? Acute bronchitis is typically a self-limitation condition. Its treatment primarily revolves around providing symptomatic and supportive therapy. For elevation cough, not pharmacological and pharmacological appropriate can be considered. Therapy for previous acute respiratory infection. It can be intoxication therapy, hypothermia treatments, including NSAIDs such as paracetamol or ibuprofen, expectorants and mucolytics such as amoxicillin or Ambrexol, bronchodilators such as salbutamol, phenytoin. The form is an aerosol inhalator or solution for inhalation using an nebulizer, or it can be combination phenytoin and ipratropium bromide. Antibacterial drugs include amoxicillin together with clavulanate, cefuroxime, azithromycin, clarithromycin, levofloxacin, in specific for atypical form of acute bronchitis. Treatments in the medical rehabilitation department. It can be massage, physiotherapy methods, therapeutic physical training. Guidelines recording against antibiotic use in case of uncomplicated acute bronchitis among the otherwise healthy adults. Antimicrobial therapy is recommended only when a tripodal pathogen is identified and is with pertussis. So you can see this all it should be according to etiological factor. Antiviral treatment should be considered for influenza infection. If we know that adenoviral infection, it can be supportive therapy, antisus drugs, and NSAIDs. If it's a coronavirus infection, it can be antiviral infection used for patients with mild to moderate COVID-19 who are at high risk of progressing to severe disease. If it's an influenza virus, we can use antiviral drugs such as inhibitor of neuraminidase, such as oseltamivir or zanamivir during 5 days. If it's an other infection such as parainfluenza, respiratory syncytial virus, or rhinovirus, only suppurative therapy. And bacterial pertussis, we can use first-line therapy macrolides. Differential diagnosis. Other potential causes of acute cough can be considered, especially when the cough persistent for duration including more than 3 weeks. Other conditions are considered as follows as it can be bronchial asthma. Bronchial asthma exacerbation can be frequently diagnosed as acute bronchitis with around 1/3 of patients presenting with acute cough. Acute or chronic sinusitis, bronchiolitis, COPD, gastroesophageal reflux disease, viral pharyngitis, heart failure, pulmonary embolism, and pneumonia. Now we're talking about pneumonia. Pneumonia, this is a group of acute infections. It's mainly caused by bacteria-caused disease, different in etiology, pathogenesis, and morphological characteristics, characterized by focal damage to the respiratory parts of the lungs with the obligatory presence of intra-alveolar exudation. We're talking about classification of pneumonia, and we should divide into 4 big groups. Community-acquired pneumonia, and now we're talking about community-acquired pneumonia only. Hospital-acquired nosocomial pneumonia, it's another name of this pneumonia. Pneumonia that occurred in the patient no earlier than 48 hours from the moment of hospitalization. Pneumonia is patient with immunodeficiency. It can be patient with HIV infection. And aspiration pneumonia. Depending on the volume of the lung tissue damage, we can divide into bilateral pneumonia and unilateral pneumonia, left or right side pneumonia. And then we can divide total pneumonia with all of the one lung, lobe pneumonia damage to the lobe of the lung, segmental pneumonia damage of one segment or several segments, subsegmental pneumonia damage of part of the segment. What does mean community-acquired pneumonia? Community-acquired pneumonia, CAP, is diagnosed in a patient disease develops outside the hospital on the first 48 hours after hospitalization. Severe CIP is a special form of the disease characterized by severe acute respiratory failure and with sepsis. Slowly swollen CIP, absence of radiological resolution or focal infiltration changes in the lung within 4 weeks or their progressing after, accompanied by a slow resolution of clinical symptoms of CIP, with related achievements of clinical indicator stability. Nosocomial pneumonia, it can be 2 types, early or late nosocomial pneumonia. Nosocomial is the same like in hospital. Early nosocomial pneumonia less than or equal to 4 days within risk factors for the presence of multi-drug resistant pathogens. It's very important for us according to treatment. Late nosocomial pneumonia greater than or equal to 5 days with risk factors for the presence of multi-drug resistant pathogens. Clinical classification taken into account the condition in which the disease developed. Community-acquired pneumonia with predominant infection by streptococcus pneumonia, mycoplasma pneumonia, Haemophilus influenza in a medical stage. The list of potential pathogens of CIP includes more than 100 microorganisms. It can be all bacteria, viruses, fungi, protozoa, but Streptococcus pneumoniae is the most common pathogen, recording for up to 30–50% of causes of CIP of established etiology. Hospital-acquired nosocomial pneumonia with predominant infection by Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, antibacteria, associated others of microorganisms. Immunodeficiency pneumonia with predominant infection with Pseudocyst carinii, Staphylococcus aureus, Pseudomonas aeruginosa, fungi, cytomegalovirus, and associated of microorganisms. In pathogenesis, there are 4 known pathogenic mechanisms that can cause the development of CIP. Aspiration is the first and main mechanism of the pharyngeal secretion. The main route of infection is the respiratory tract of the lung. Inhalation of aerosol containing microorganism, hematogenous spread of microorganism from the extrapulmonary source of infection. Direct spread of infection from airborne infected organs or as a result of infection in penetration chest wound. Clinical picture of the disease. It can be characterized by an acute cough, shortness of breath, sputum production, or chest pain associated with breathing, which is most causes in accompanied by fever. Patients suffering from pneumonia often complain of unmotivated weakness, fatigue, chills, and severe sweating at night. In clinical pictures of the disease, we can see in specific according to type of the person. In elderly and senile people, typical complaints can be absent. It's very important. Intoxication syndrome comes for the clinical picture of the disease. Growing anxiety, confusion, anorexia, nausea, vomiting, or decompensation of chronic disease. It's the decompensation of diabetes mellitus, chronic heart failure. Pneumococcal hepatitis by an acute onset with heart fever and chest pain. Legionella hepatitis by diarrhea, neurological symptoms. Mycoplasma is a typical form of pneumonia, is associated by muscle and headache symptoms of upper respiratory tract damage. Despite the presence of certain features of the clinical picture and course of CIP of various etiologies, there are currently no patterns to make it possible to predict and consider agents of the disease with a high degree of reliability without the use of additional research methods. Criteria for diagnosis of pneumonia. Diagnosis of CIP is treatment in a patient as radiologically confirmed focal infiltration. It's a main diagnostic criteria of the lung tissue and at least two clinical symptoms and signs from the following. It's an acute fever at the onset of the disease with a high temperature more than 35. Cough with sputum or physician signs, focus crepitation, it's very important, or rales, bronchial breathing, shortness or percussion sounds, leukocytosis more than 10 or and band shift. On physical examination, all patients with CIP is recommended conduct a general examination, measure indication of viral function, respiratory frequency, heart rate, BP, blood temperature, body temperature, and perform a detailed examination of the chest. Integral components of diagnosis, assessment of the severity of CIP and prognosis. According to laboratory diagnostic tests, all patients with CIP are recommended to undergo a general clinical analysis of blood with determination of the level of red blood cells, hematocrit, leukocytosis, platelets. Leukocyte formula for the establishment of diagnosis, assessment the severity of CIP and forecast. Data from a general blood test are not specific and do not allow us to speak about the potential causing agent of CIP. However, leukocytosis more than 10 with the increase of the level of neutrophils or benchmark more than 10%, neutrophil lymphocyte ratio indicate a high probability of bacterial infection. Leukopenia, thrombocytopenia, and hematocrit less than 30 are unfavorable diagnosis signs of CIP. Laboratory diagnosis test. All hospitalized patients with CIP are recommended to have their blood levels tested. Serum C-reactive protein to establish diagnosis, assess the severity of CIP and prognosis. The level of CRP correlates with the severity of the course, the prevalence of inflammatory infiltration prognosis in CIP. All patients with severe CIP are recommended to have procalcitonin levels tested in the blood quality test to assess prognosis. A general therapeutic biochemistry does not provide any specific information for CIP, but detected duration may include the presence of organ dysfunction, decompensation of associated disease, and the development of complications have the certain prognosis significantly and influence the choice of drug or the dosage regime. Microbiological diagnosis of CIP includes microbiological culture examination of sputum or the respiratory samples, tracheal aspirate. Instrumental diagnosis studies. Instrumental diagnosis studies for pneumonia includes Radiological search methods. Radiography. Plain radiography is recommended for all patients with suspected CIP. In the arterial direct and lateral projection, is the localization of the inflammatory process is unknown. It is visible to take a picture of the right lateral projection in order to verify the diagnosis, determine the severity of CIP and prognosis, and identify complications. CT of the chest organs, ultrasound examination, ECG. CIP, in addition to the compensation of chronic contaminated disease, increase the risk development of rhythm disturbance and acute coronary syndrome. Also cause for older patients, and you should remember about it. The time and direction of which significant affected the prognosis. In addition, certain changes in the ECG, for example, prolongement of the QT interval, the presence or early ventricular position syndrome, increase the cardiotoxicity of the number of systemic antibacterial drugs. Severe CIP can be defined. First, respiratory failure requiring mechanism ventilation. Septic shock with needed for vasopressin. The presence of any of the three minor criteria. Minor criteria of severe. Respiratory rate more than 30 breaths per minute. Saturation of oxygen less than 250. Multilobar infiltrates. It can be disorientation, confusion, uremia, leukopenia, thrombocytopenia, hypothermia. And hypertension requires recessed fluid resuscitation. Now talking about treatment in our patients for CIP. Antibacterial therapy. All patients with a defined diagnosed CIP are recommended to prescribe a systemic anti-inflammatory drug as soon as possible. Optimally no later than 8 hours from the moment of verification of the diagnosis to improve the prognosis. For outpatient with established diagnosed CIP, oral dosage forms are recommended. In-flight pneumonia caused by SARS-CoV-2 bacterial co-infection area, which determines to appropriate, often including systemic antibacterial drugs, is routine protocols for the management of this category of patients. According to guidelines to the management of community-acquired pneumonia, it would provide admitted, not being admitted to the hospital, admitted to the hospital. For patients not being admitted to the hospital, it's without no comorbid conditions, you can provide only amoxicillin. Alternatives are macrolides or azithromycin, clindamycin in the case of a typical form of bacterial infection, bacterial pneumonia. If a comorbid is present, such as malignancy, alcoholism, asthenia, diabetes, chronic heart or lung or liver or renal failure disease, we can use amoxicillin together with clavonate or cefuroxime plus azithromycin, or alternative we can use respiratory rohypnol. Severe beta-lactam allergy, we can use rohypnol, levofloxacin or moxifloxacin. If the patient is admitted to the hospital, not severe and severe, non-severe, we can use ampicillin, sulbactam, or ceftriaxone. It's intramuscular intravenously. Way of introducing plus azithromycin or doxycycline preferred, or levofloxacin. With severe, it means septic shock, respiratory failure, or three minor criteria, we can start with amoxicillin, sulbactam, or cefuroxime plus macrolides, azithromycin, or levofloxacin. It's severe beta-lactam allergy, levofloxacin. The duration of antibacterial therapy for CIP is determined individually. When deciding whether to consider systemic antibacterial therapy for CIP, it is recommended to be guided by criteria for the suitability of bacterial therapy. All the following must be present. Persistent disease of body less than 37.2 for the least 2 days, 48 hours. Absence of intoxication syndrome, respiratory rate less than 20 per minute, absent of purulent sputum, and number of leukocytes in the body less than 10, neutrophils less than 80, urinary force less than 6%. Patient with CIP can be you can prescribe paracetamol and other NSAIDs and antipyretic drugs such as ibuprofen as antipyretic drug or analgesics. As well as drug can improve the virology of bronchial secretion, you can prescribe ambroxol or acetylcysteine. And of course, if a patient smoker, you should prescribe a patient to stop smoking, excessive physical activity limit temporarily, and consume specific fluids. This is example formulation of the diagnosis of pneumonia. It should be started from the first main words, community acquired or nosocomial pneumonia, then localization of the lobe site, then etiology, then severity, complications, and the respiratory failure degree. And then I have a task, five tasks for you. This is the first task. Please, you should in the practical classes see what you can see on these X-rays, this X-ray, and you should say me what can you see here. First task. This is the second task. And please try to find the pneumonia. So task for all of these five tasks, it's really patient from our polyclinic. This is a fourth, and please fifth. So I'll be waiting from you the right diagnosis of the pneumonia, where you can find and decide where is it. So good luck, see you in our practical classes.